Hypermenorrhea refers to a case where there is more menstrual blood loss or a longer menstruation period than usual. It is the most common uterine symptom for seeking a doctor, which affects about 10 to 20% of women in childbearing age. The hormone imbalance causes the inner wall of the uterus to thicken or the inner surface of the uterus to grow bigger. At the end of menstrual cycle, when the functional layer of the endometrium is at its thinnest, this will be the easiest time to ablate the basal layer of the endometrium. Ablation of the basal layer reduces the production of functional layers during menstruation. RF Medical's EMT electrode is easy to use, effective, and has a short treatment and recovery time. If needed, a Hegar dilator is used to widen the cervix before inserting the EMT electrode. Practitioner can choose which areas of the uterus to ablate.
There or not. Now we are going to do endometrial ablation. Okay. This is the special antenna, angled antenna, blunt tip, active tip is 3 mm, and you see this is the 20 gauge. So this is a transvaginal, transcervical endometrial ablation. This case of submucous fibroid with the endometrial hyperplasia, patient complains severe bleeding PV, menorrhagia, anemia. We have transfused 3 units of blood. Now the patient taken to surgery. So new concept, a novel technique, a minimal invasive, ultrasound guided transvaginal, transcervical endometrial ablation. Okay, thank you. He is Dr. Praveen, he is a radiologist. Dr. Sopna, gynecologist, Dr. Neeraj, Kechoda, general surgeon, the team, MDT, multidisciplinary team, we are going to do. Dr. Ajar from anesthesia. Right, thank you. Section on this. Relax, no tension. Now got it, light is okay, disturbance in the light is done. So take out light, sorry, side station. The back up.
Okay.
No, I reached the fundus. I should go
At the
back.
same time, to the that windows.
The technique is 1 cm endometrium 50 watts at 10 seconds. 10 second, you have moving shot technique.
Okay.
Right? So, you see the my, you see, you take out this, remove it, very rara. Now show me clearly, no problem, zooming out, very rara. Now show me clearly, no problem, zooming out, come this side, otherwise come this side.
Okay.
Right? Okay?
This is the tick.
Get some, this is antenna moving, over there is a submucous fibroid. Right? So, foot switch.
So,
Right.
so let them know that you are in uterus now.
Who will ask? Anybody confirm this? It's in uterus.
It is in uterus.
Yes. We can see the bladder full and the Foley's bulb with the
Yes.
Foley's. It is a uterus. Kunchum clarity. Yes. Now you see. Now you can. Firing is started. Firing started. Now this you can see the white gasification. No moving. Probe is.
10 seconds.
The probe is complete. Yes. Now you can see the firing over there.
Yes, sir.
Zooming out, camera, anybody can see the firing over there, and it should not reach the myometrium bladder. we are doing endometrial ablation only. Right?
30 seconds.
30 seconds. You see I'm withdrawing. And you can see the firing is going on.
40 seconds.
50 watts,
50
10 seconds shot for this. Yeah, moving shot technique. I am at the internal layer of endometrium. You can see the firing, you can see the ultrasound guided.
Yes, sir.
Okay? You are saying the firing?
Yes, sir.
You confirm it?
Yes, sir.
It is I am internal layer of endometrium, you see the uterus.
70 seconds.
Okay, no problem. Okay, any doubt? Now it's very clearly seen and endometrial ablation. One side I have done the firing, I have to go that side, left side I am doing.
Yes.
Try to understand, okay?
Yes, sir.
Within the internal part of the endometrium fetus.
99 seconds.
Yes, okay, I will check. You can see the white layer post ablation also. This is a moving shot technique, okay?
Yes, sir.
Now I am moving to the right side here.
Yes.
You can see this endometrial
Lining.
lining debris.
Yes.
Okay.
Yes.
So this case of all the mucus, hyperplasia of endometrium. Okay. So this is an internal uterus. We are going this side. This is, you can see, this is different antenna. This is the only one antenna I have in India. It's like, you have to reach all this corner and as well as this corner of the uterus, cornual structure.
Got it.
Right? You got it?
Yes, sir.
Ostia. If this side ostia, this ostia. So we have to. No, we have done left side. We have to go for right side. So patient left side. Okay?
Yes, sir.
Right. Again, I am inserting transvaginal from this end. Please. From the vertical light, please. Yeah, no problem. There are phone light also. No problem. Yes. Section 100. Section 100.
Section on. Button sir.
You can see all the debris, dead material is coming out. Like this, endometrial. Okay, what you done, D and C you do now? Yes. Right. So, take out this. Section on. This is the entry from the transvaginal, transcervical, going to the inside the uterus. Okay. Now you see. Okay, inside. Fundus I reach. Come back. Clear. I'm doing. And the white gasification also come down, right? I'm moving inside. Lower one. Yeah.
And what is the shadow sir, which is traveling over in the urinary bladder?
Police bulb.
That is the police bulb. But the one shadow is being traveling by your
This one.
Huh?
This one.
Yes.
That is anterior layer.
Got it.
Police cube. This one you are.
No,
Okay.
we have ablated this. This is
yeah.
ablated. Endometrial cavity ablated. You see
Yes.
this.
So this is
Yeah. Yeah, this is ablated.
Got it. Now we are ablating the left wall of the
Yeah. Okay, it's over. Case is over. You can see endocervix.
No bladder, urinary bladder. और जो यूरिया है वो
This
police
you
के
cannot
अंदर है.
reach. Right. No, surgery is over. Endometrial ablation is done. Right. This is a novel technique, and a minimal invasive technique with ultrasound guided transvaginal transcervical endometrial ablation with a microwave.
For
so,
the
so many
indication-
techniques.
for the
Indication is there is an endometrial hypoplasia, you call it DUB, dysfunctional uterine bleeding. So all the case, all hospitals are subject to hysterectomy. This case, other hospitals are subject to hysterectomy. So they came for save uterus, we preserve uterus, we have done the endometrial ablation. Okay, we'll put a drain, copper drain T. Just we do DNC, we'll do copper T inside. It will act as a drain. Okay? The case is over. Right, thank you. Thank you.
Thank you, sir.
Now we'll have presentation.
And if we are having 3 layers, the innermost